One of the key parts of this presentation is that we have some of our infection control practitioners here to actually demonstrate the appropriate donning and doffing of PPE, or personal protective equipment, which is, as you'll see, a healthcare worker's best way to prevent infection, which is for every type of infection, not just Ebola. So what I'm going to talk about today is try to give you an overview of what Ebola is, where it came from, how do humans get it, what's happening in Africa right now, how to protect yourself if you're a healthcare provider, how Nova Scotia is prepared, and then just review some interesting modeling data about where the future could go if things are not curtailed. So what is Ebola, where did it come from, and how do humans get it? And this is what Ebola would look like under an electron microscope, the pink picture up there. Ebola is a virus. It is an envelope virus. So an envelope virus means it's not as hardy as some other viruses. It's easily killed by disinfectants. So that's key, because what we use to disinfect our areas normally will actually kill this virus. It belongs to a group of viruses. So the Ebola is kind of like the genus name. There's a whole bunch of different Ebola strains based on where they have been isolated. Ebola Zaire is one of the first ones that was identified, but you can see there's a whole bunch of other ones. And each strain has its own characteristics in terms of how lethal it is and where it comes from. Where did it come from? This is a map just demonstrating the Ebola outbreaks that have occurred since 1976. And you can see that the vast majority of outbreaks have occurred in the central portion of Africa. And I've equated Ebola as kind of like a terrorist. It tends to come in, it kills, and disappears. And that's how Ebola has generated fears, because you can never predict it. And the difference between what's happening now, as I'll get into a little bit more, is that these traditional outbreaks have occurred in rural areas. So these are isolated areas where there's not a whole big population for it to go through, and it tends to burn itself out and disappear. Many of you may have read The Hot Zone. It was a book by Richard Preston in the early 90s. And they really have a more Hollywood-type account of how Ebola was discovered, particularly how it infected monkeys and things at a research facility in the States. But I do suggest that you read it if you want to find out more information. For the longest time, we had no idea where it came from, but we now know that the virus actually lives in bats. These fruit bats that are common in many places in the world, including Africa, is where these things tend to live. They normally circulate within the bat population. Bats are actually fascinating animals because they actually can harbor a whole bunch of different viruses, many of which are these emerging pathogens we worry about, like SARS and MERS-CoV and that sort of stuff. But the Ebola virus has been identified within this bat population. And you can imagine that there's tons of bats in Africa, and there is an opportunity for it to spill over to humans. But the way that it tends to do so is either direct contact with the bat or direct contact with an animal that the bat has infected. Once it gets into humans, then we can transmit it among ourselves. But if you look at how humans actually get it at first, it's usually direct contact with one of these animals. The top corner there is bat soup, which apparently is a delicacy in some of the African countries that currently have the Ebola outbreak, and has been banned right now because, again, these bats are a source of Ebola. Down in the bottom corner, you can see a monkey. This is basically an example of the bushmeat market that exists in Africa and has spilled over into many developed countries as people move from Africa and expect to have the same sort of delicacies that they're used to. That's also a dangerous way of bringing viruses from the animal kingdom back into humans. You can imagine that we are very close to monkeys evolutionarily. If a monkey virus infects them, it's more likely to be able to infect us. And in fact, the Ebola outbreak that's happening now in the Democratic Republic of Congo, which is different than the big one we worry about — there's actually 2 Ebola outbreaks right now — that is thought to have occurred when a woman was preparing some bushmeat that her husband provided for her. She got sick and she infected a bunch of people. So it's these contact with the animal world that is really what brings Ebola into humans. Now, when it gets into humans, we can be infected by direct contact. So it's not aerosol transmitted. It's not like measles or chicken pox. You actually have to have direct contact with contaminated fluids that are infected with the virus. And these are generally blood, other secretions, urine, feces, semen, and breast milk. In fact, it can remain in some of these secretions long after you've recovered from Ebola. For example, It can be present in semen for up to 3 months, and they actually recommend that people use barrier precaution once they recover for that time. The other thing, of course, is that you can be exposed to contaminated materials, whether it be the fomites, the area that they work in, or medical instruments. And, of course, if you have a needle stick injury, that's another way to transmit it. But generally, the virus or the fluids have to get in past our innate barriers, and that's skin. So you've got to have a break in your skin or a mucosal surface or a needle stick type injury. These pictures just sort of reflect what the reality is in Africa. One of the big ways that this virus is being transmitted is how people deal with their dead. So when a person dies, the fluids that they have are actually quite infectious. And depending on the cultural aspects of the area that this virus outbreak occurs, people have different ways of mourning their dead. And part of that is helping with the preparation before burial. And you can imagine that most people don't use personal protective equipment when doing so. And that was one of the ways that this virus was being transmitted in communities. And it is a very difficult messaging to get across that you can't do that because people have entrenched beliefs, and it's very difficult to try and educate how to do things differently. But that is one of the things that people are doing. So just as important to understand how it's transmitted is to understand how it's not transmitted. So this is just a poster that the CDC has developed. You can't get it through the air. As I mentioned, it's not spread by aerosols. There is some animal data to suggest that if you did induce it in an aerosol, it could spread, and that's why, as you'll see with our healthcare PPE recommendations, if you're doing an aerosol generating procedure like a bronchoscopy or intubation, then you would want to make sure that you provide the appropriate protection, which is an N95 mask. But for general purposes and general care, it only is droplet precaution. A surgical mask is sufficient. You don't need to worry about aerosol transmission. You can't get it through water. You can't get it through food unless it's undercooked monkey meat, which is usually not an issue in North America, or bats, as that bat soup showed. And in fact, if you discharge the fluids into the sewer system, it's not a risk to the community because the sewer system would actually inactivate the virus anyway. So there are lots of ways that you can't get the virus as well, which is just as important to understand. And it's also important to understand that patients are only infectious when they're symptomatic. So when they don't have symptoms, they're not at risk, which is important from a public health perspective because it's not like influenza where you can be infectious for 24 to 48 hours before you have symptoms and you're more likely to be acting normal and spreading it. This only gets spread when you actually have symptoms. So what's the current situation in West Africa? So this was released by the WHO last week, and it basically provides you an overview of the areas that are infected with Ebola. It is focused in West Africa. We've got Guinea, Sierra Leone, Nigeria is over here, and Senegal also has a couple of places. But the predominant infections are occurring in Liberia, Sierra Leone, and Guinea. And you can see that as of September 7th, there's been over 4,000 cases of Ebola with a 51% mortality rate. Now, the two other areas, Nigeria and Senegal, are considered what they call localized infections. It's not widespread. It's not out of control like it is in the top three. And that's important from a public health messaging perspective because the risk is different. Just because someone's been to Nigeria, their risk of getting Ebola is much less than, say, if they were in Sierra Leone. So it's really important to actually look at where the person's been and what they've been doing in terms of their risk. And as I said, the Democratic Republic of Congo actually has its own Ebola outbreak, which is genetically distinct and different from the other West African outbreak. So you can see that the mortality rates certainly differ. And quite frankly, I have no idea what the mortality rate would be in North America, but I suspect it would be quite a bit less, as I'll tell you, most people die of hypovolemic shock. So if you can actually support them through this, you're more likely going to survive. So you can imagine in Africa, they don't have the capability to do that. So now that you know what your risk is in terms of your exposures and where you have to be to have gotten it, the other thing we have to understand is what are the symptoms that they usually get. So Ebola, unfortunately, presents like many other infections. It's very nonspecific at the beginning. It's like a flu-like illness. One of the keys is that you have to have fever. Generally, we define that as 38.6 or greater. The incubation period is anywhere from 2 to 21 days, but is generally within 4 to 10 days of exposure. And on the side here, I sort of listed the non-specific symptoms, which you can imagine are very common for many other sort of respiratory tract infections or gastroenteritis. One of the things that apparently is helpful in differentiating this is cough is not common, where it would be quite common with influenza. And the rash in the conjunctival injection, this is a picture down at the bottom of an Ebola patient. You can see that the pinks of the eyes are quite red, and that's because of the injection they get with this infection. And that's certainly not a common feature of the other sort of infections that you would worry about, influenza being the big one that might present during flu season in a similar fashion. About 50% of people will go on to get hemorrhagic infection or hemorrhagic manifestations. And Ebola generally follows a typical pattern, where you have early infection, which is this non-specific flu-like illness that can progress to much more severe symptoms, to the point where you can get bleeding and either you survive or you die. And most people will die within the first week to 2 weeks of multi-organ failure, usually due to hypovolemic shock. But if you survive, most people will survive, generally have a milder course. They have fever for 5 to 9 days, and then they improve. And when they've looked at the people who've survived, it generally coincides with the point at which their body starts to make antibodies, one of the primary ways that we fight off infections. And that's important because you can actually leverage that by trying to give people antibodies to prevent the infection or to help fight the infection. Complete recovery can take many weeks, and actually you can have these post-infectious symptoms for quite some time: arthralgias, headaches, weakness, which you can imagine if you've been through a significant infection. Many people have that anyway. The mortality rate, again, ranges depending on the strain, 30 to 90%. Currently it's 50% in the Western African outbreak. But again, because treatment is supportive, and in Africa the healthcare infrastructure is so poor, it's very difficult to provide that level of care. And you can imagine that if they did get to North America, that the success rates would be much higher. Now, that said, 4,000 patients is a lot, and we would be worried about overwhelming our system. But again, it's the supportive care that is probably going to differentiate how they survive here versus there. So one of the questions we always get is, well, you know, how does the virus kill? And just for the pathologists in the room, generally the virus can infect endothelial cells, so the cells that line blood vessels. When the virus infects them, they cause damage. It can cause leaky blood vessels, which contributes to your shock. But the other thing it does is it infects certain immune cells, macrophages, monocytes, things that the immune system uses to prime the immune system, to present it to the entire body to say, hey, there's an infection here. And what the body does is it reacts to this presentation by secreting chemicals or cytokines. These are the things that make you feel crappy when you have influenza. So the reason why you've got weakness and fever is your body's response to those viral infections. And these cytokines generally are good because they help kill the virus in the surrounding tissue. But your body has to be able to balance that. It's a delicate balance, and what happens with this particular infection is you get what's called a cytokine storm, where your body can't actually balance that, and it becomes overwhelmed, and as it tries to get rid of the infection, it actually causes damage, and you end up getting more and more shock, and it can kill you. And that's how some of the bleeding can occur. In terms of the lab findings that we typically see, we would see that their white cells will be low. They tend to be anemic. Their platelets are low. This is, again, not specific to Ebola. We see that with a lot of severe infections, severe sepsis. In viral infections in particular, we often see the lymphocytes or another component of our immune system drop. And that's probably secondary to, again, the body's response is trying to kill the virus, and part of that is making sure that it kills the cells the virus is in, and as a side effect, some of the white cells get killed. You can see atypical lymphocytes. You can see that the patient can then go on to progress to disseminated intravascular coagulation, or DIC, which essentially means that they can't control their bleeding and they bleed from their mucosal surfaces, which is what's the scary part that you always see in the movies, is these people bleeding from everywhere. Ultimately, it leads to multi-organ failure and they die. Again, supportive care being key. So obviously people want to know how to manage these patients. You want to do it in the best way possible. As you can imagine, Ebola is not common. There is no randomized control trials in terms of treatment. There is no specific treatments that are currently FDA approved or Health Canada approved. So when the Ebola outbreak happened, there was a lot of chatter across the country and a great collaborative effort between the critical care groups, the emergency groups, and the infectious disease groups across the country came together and actually generated some guidelines on how to manage them. And I've given you sort of the website there, but essentially if you Google guidelines Ebola in Canada, this will come up. It's on the PHAC website. It'll direct you to these guidelines. And essentially it tells you how to protect yourself. So as healthcare workers, you need to protect yourself, and that's through contact and droplet precautions, as we'll see in our demonstration shortly. It really is supportive therapy, making sure that you aggressively fluid resuscitate, transfuse when necessary. The nuanced difference there is that you cannot do cross-matching safely, so the recommendation is actually that you give ORH negative blood because you can't cross-match safely. And then you need to make sure that they don't actually have something that's more common. Because the reality is that when people come from Africa, they're a heck of a lot more likely to actually have malaria than they are to have Ebola, even in the regions from which Ebola is coming. Malaria is much more common, and malaria will kill you just as fast and probably faster than Ebola. As many people are aware, there was the case in New Brunswick that turned out to be malaria. You know, there have been cases in Quebec that have been suspect Ebola cases that turned out to be malaria or influenza. So you got to rule out the more common things. And there are other travel-related infections too, typhoid, other types of gastroenteritis fevers. These are the things that we need to consider and to look for, because ultimately we have to manage the patient. And most times it's not going to be Ebola. Now, having said that, because you want to limit the exposure to blood, because blood is an infectious fluid, the guidance is that you only do essential tests. And what that includes is essentially a malaria smear, CBCs, and lights and creatinine. That may be a challenge, because you can imagine if somebody from West Africa who's 55 and a diabetic and hypertensive and presents with pain in their left arm, regardless of the fact that whether or not they've been in Sierra Leone in the last 21 days, you're worried they may have a heart attack. And the challenge will be to try and provide the appropriate care to support that individual. And I think that as we see things evolve, people will realize that the minimum CBC and lights may not be necessary or may not be adequate. It's a point of evolution, what we can do safely and what we can do to manage the patient. In terms of specimen collection, because blood is so infectious, this is different. So for the people that work in the ICU or people who work in emergency, when you draw the blood on these people, you're going to have to treat it slightly different. The first thing that needs to be done, as Robin will tell you, is as soon as a risk of potential Ebola is identified, you need to discuss it with the medical officer of health before you even draw any blood, because specimen collection is different. It's different in that you actually have to clean the outside. It has to be transported to the lab following what's called Transport of Dangerous Goods. It's a federal act that means you have to wrap the specimens a certain way. They have to be in this bomb-proof container. And in fact, the person there's only 4 or 5 people in the lab right now trained to package it appropriately. They actually have to then escort that package to the lab if it was in the emergency, for example. So the transport is completely different. So you need to make sure that everybody's aware and that communication is good. When we test it, we have to test it differently. So because of the concern of the infectiousness of blood, the current recommendations are that the large analyzers can't be used because you can't adequately disinfect it. There's concern that it may put healthcare workers at risk. Quite frankly, I think that's going to evolve as well as the people pressure the manufacturers for appropriate decontamination methods. You'll see probably that these analyzers will be able to be used at some point. But right now, because of the unknowns, what we've decided is that we won't use these large analyzers. We'll use these point-of-care equipment. So this is a piece of equipment that does CBCs. The little piece of equipment on the side does electrolytes. The blood is transported directly to the microbiology lab, and the microbiology techs will actually do the CBC and the lights for the patient, rather than it being disseminated into a bunch of different divisions. Again, trying to satisfy the caveat of limiting potential exposures to healthcare workers. The other thing is that all of this has to be done in a biosafety cabinet, as you can see there, with enhanced PPE. Now, nursing staff's going to notice that's an N95 in the lab. As soon as you start to open aliquot and centrifuge things, you have the potential to generate aerosols, and that's the reason why the lab workers have to wear an N95, whereas patient care, you don't necessarily have to. People who are drawing the blood, even if it's a lab worker, would need an N95 because you're not going to generate an aerosol. Again, it's this risk assessment. It's this at the point of contact risk assessment, which is the new paradigm for all infection control, not just Ebola. And that's going to be one of the key messages in this talk. The other thing in terms of managing the patient, you have to risk what you're going to do to putting healthcare workers at risk versus how well it's going to help the patient. They say limit lines, again, balancing what's necessary to what's going to be risky. Non-invasive ventilation is not recommended because that has the potential to generate aerosols, put other people at risk. It also forces air into their stomach. There's increased risk of vomiting. There's all that sort of stuff. So they basically say if they're on the way to get tubed, you tube them electively and you do it safely. CPR is not justified. So the studies, and the ICU folk here will know this a lot better than I, suggest that even if you don't have Ebola, if you code in the ICU, the chances of you recovering, if you present with hypovolemic shock, etc., are very low. And in the circumstance of having an infection that puts other people at risk, they recommend don't even try. The chance of you surviving is so low, you're going to put other healthcare workers at risk. So that's also in the guidelines. And again, there's no targeted therapy at the moment, but at the end I'll sort of have one slide to say, well, what does the future offer? So at this point, we're going to have our infection control practitioners to come down and actually demonstrate how to put on protective equipment and how to take it off appropriately, because this is the most important thing from a healthcare perspective, healthcare worker perspective.
We're going to demonstrate PPE, like Dr. Hatchett has said, is based on the risks that you're going to entail. So what is it that your patient is experiencing? So are they coughing? Are they vomiting? Do they have massive amount of bleeding? What is it that you're going to be exposed to is the first question you should ask yourself. The next question is that what are you going to be exposed to? So what kind of secretions? Are you going to be exposed to blood or vomit or feces or anything that might contain those virus particles? So we're going to do the enhanced PPE, as you saw there in the slide. So Sharon's done her hand hygiene. The first step is to put on booties. The booties might not be necessary unless your patient's experiencing hypovolemic shock. You know, they're bleeding out, they're hemorrhaging, and you're going to be exposed to mass amounts of blood, maybe vomit. And the more the reason for these first is just for ease of putting it on. So the sequence for putting on PPE is more of the ease of getting it on. If you happen to put something on backwards, not backwards, but in the wrong sequence or the wrong order, that's okay as long as you've got it all on. But we'll talk about the importance of taking it off in a few. So next she's going to put her gown on. It's an impermeable gown, so it's waterproof, fluid-proof, fluid-resistant. Fastens in the back. Neck is always first. Ties around the waist. If you find that it's not covering, so your gown isn't large enough and it's not covering your back, you might want to wear two. So you would put your first one on like a house coat and put your second one on this way. So she's got her gown on. Next, she's going to put on her face mask. So either a duck-billed surgical mask or a regular surgical mask. Ties in the top around her ears and around her neck. So if at this point you were doing an aerosolizing generating procedure like a bronchoscopy, an intubation, instead of a surgical mask, you'd have an N95 or a respirator mask would go on at that point in time. Her face shield is next. It's a bit different than our droplet mask that we would use for influenza. We've got a bit more coverage with this face shield so that it protects your neck a bit better and your front of your face. And next she's going to put on her OR hat. It's mostly for if you had any kind of scalp lesions, any time that you might be, again, exposed to mass quantities of fluid, you're going to want to cover your head. So she's fit that around her and it's looking good. She's all tucked in. Her buddy's telling her she's all tucked in. And last, of course, she's going to put on some gloves. So if you happen to put on all your headgear first and then your gown, that's okay. It's not going to change the way that it protects you if you happen to reverse the sequence. We do have some sheets that basically are a checklist of how to put things on, how to take things off, that we'll provide to the units that will be receiving these patients. So she's got it all on. She's really hot now and probably steaming up for glasses. So we're going to worry about the removal. So you always go from most contaminated to cleanest, basically. And typically we would start with gloves. Our normal order of sequence is gloves. But because we have booties on, they're on our feet and they're considered the dirtiest. So she's going to take those off first. Being careful not to, expose any fluids onto her maybe her scrubs, her footwear. We'd have a garbage can if we were in a regular room that she could dispose of those. So you can kind of roll them off, trying not to splatter as you take them off. So she's got her boots. She's going to take her gloves off next because they're considered the next dirtiest. And you're careful to make a pocket so that if there was any fluids on those gloves as you were taking them off, you kind of pocket it to dispose of it. Next comes the gown. So we untie it, usually the bottom first, top last. And as she takes it off, she's going to remove it so that she doesn't, you'll notice that she's not contaminating the front of her scrubs or the front of her clothing. So she's taking it off, again, kind of making a little pocket and away from herself so that she's not taking those fluids with her. And she's rolling that and disposing of it. I should have mentioned earlier when we were putting it on, they'll come in a little package like such, but for ease of demonstration today, we've taken it out of the package to put it on. So now, because she's worked with the dirtiest, she's going to wash her hands using Purell, perform hand hygiene for 15 seconds, covering all the surfaces. We get the nails and everything. If at this point, alcohol is really made to get you to a sink with soap and water if you've contaminated your hands. But we use alcohol in the taking off just because it's more efficient to do that. So she's going to go to her head next, take off her cap by taking it off from the back, because that's the least contaminated to the most contaminated, to remove it from the back. She can, at this point, take off her visor. And she's again going to remove that from the back. And we usually advise after the visor and hat to wash your hands again in case you've gotten anything on them, because you're going to your face next. So you're going to those mucous membranes. So if you do have contaminants on your hands and then you're going right to your face, that's a good entry point for those viruses. So she's going to wash before she does that. And I should note that Sharon's got her hair pinned up today too. So if you're at a bedside and you're having to wear this PPE, it's a good idea to have your hair pinned up if you have long hair like Sharon and I. It's just easier to tuck everything in. And then at this point, she'll do hand hygiene again. And if she's close to a sink with soap and water, she's going to wash with soap and water. But today we just have Purell here. We don't have a sink. So we're going to use that until we can get to a sink with soap and water as our last step.
So now we're going to get into some specific questions for healthcare workers. So what if I take care of a patient? So one of the tenets to the Ebola management plan is going to be that they'll have dedicated healthcare workers. So the person that's taking care of that patient is taking care of only that patient, not other patients. And because there will be the buddy system, and of course you need someone to spell you off on break, that means that there are 2 people taking care of that patient each shift. So again, you can imagine this would be resource intensive. You also have to remember that most of these people are not going to have Ebola, and there's going to be a 48-hour period where we're waiting for the test results to come back. If they're negative, it's back to normal standard of care. You're okay, you're not at risk, there's no concern. If it's positive, that's when people get worried. And realistically, if you follow your appropriate PPE donning and doffing, you're at minimal risk. And generally, what will be advised is that you self-monitor. And you self-monitor for 21 days, and you're fine. Again, you cannot transmit this unless you have symptoms, but as soon as you have symptoms, you let a healthcare worker know and you self-isolate it. So it's important to watch yourself after you've taken care of a confirmed patient, not just a probable patient, because, again, it's unlikely to be Ebola in most of these cases. But if you have a confirmed patient that you're taking care of, then you just watch yourself for 21 days. There is no quarantine, you don't have to stay home, all that sort of stuff. You can work. It's just you have to watch for symptoms. So why are healthcare workers infected? This is typically what's going on in Africa. This is actually a good room. You got tarps that seal it. There's one person in the room. This would be more likely what you would see. You've got rusty beds, which would be almost impossible to decontaminate because you get fluids and all kinds of stuff in these cracks and crevices. And as infection control practitioners will tell you, if you cannot remove the stool, you can't get rid of the infection if it was in stool. They are not separated. So you've got transmission potentially between patients, and then healthcare workers are dealing with an environment that is not as controlled as it would be in North America. The other example is this, and you can see we use disposable PPE. In Africa, resources are limited. They're not going to be able to dispose of it all. What they're doing is they're recycling the PPE that they have, and that includes dish gloves. So gloves you'd wear washing dishes. So imagine trying to take those off without contaminating yourself. They are then put in bleach and then set out in the sun to dry. Boots, same deal, and you can see sort of scrubs in the background. So healthcare workers are indeed at risk, but they're more likely in Africa going to be infected because of the resource issues. They don't have disposable PPE. They're doing the best they can with what they have. And it's very difficult to be able to take that gear off without the possibility of contaminating yourself. That lumped onto the fact that they're probably working long hours. There's very few of them there, highly stressful conditions, all of that sort of stuff, which can happen here as well. But the difference being is that we have greater access to the resources. So again, much like patient management differs, infection control is going to differ in Africa. And that's probably why most healthcare workers are getting infected. Even the doctors and the nurses who are well-trained in North America are getting infected, probably because the PPE gear is not to the same standard that they would have here. So with that, I'm going to quickly change to Robin Taylor. I'd like to introduce you to Robin Taylor, who is one of the medical officers of health at Capital. And she's going to talk about the preparations for Nova Scotia.
Last slide. I think it really highlights that the reason that the Ebola outbreak is as big as it is right now in Western Africa is because of poverty. And that's very important when we're looking at the statistics of fatalities, of healthcare workers being infected. When you're thinking here from an occupational health and safety and just a planning, it's very, very different here. So yes, please do be calm. And we are prepared. We have really good planning in Nova Scotia, and I'm smiling because I'm an integral part of it, which we'll see in a little bit. there's been a lot of communication between EHS, the infectious disease physicians, the different sites, the different DHAs in Nova Scotia, Department of Health and Wellness, Public Health. And here's some of the information from the plans sort of just distilled. So if there is assessment needed for somebody in Nova Scotia, and it's a child, IWK is the assessment site, and if it's an adult, they will come to CDHA. And there has been planning for which rooms they will go to for this assessment and how they will get there. So that has all been taken care of. And they will have really the infection control needed for Ebola at the beginning stages is a room with a door that you can shut. But because there may be need eventually for intubation, that type of aerosol generating procedures, we're going gold starred from the beginning and putting them in negative pressure rooms with an anteroom as well. No blood work will be done. So sometimes I think in triage, blood work can be drawn before they're moved into the system, but no blood work will happen until public health and the lab have been notified. There'll be dedicated equipment, and then there's rules about healthcare workers, visitors, all of that as well. So the planning is there. I'm very confident in it. Part of the plan is the screening. So as Dr. Hatchett said, the chances of us actually getting a real Ebola patient with Ebola are very, very slim. The chances of us getting somebody who has traveled to a country that has Ebola in it, who present with symptoms that could possibly be Ebola but actually turn out to be typhoid or malaria, are much, much higher. Common things being common. Malaria, we get a couple of cases of malaria a year reported to public health. So we have no cases of Ebola at this point in time in the entire country of Canada. So screening is hugely important, and CDHA has a great screening tool. The important thing is to remember we're not screening everybody. You know, somebody comes in with a broken arm unless they have that fever. So fever is the trigger to start thinking, hey, where's this person been? And then they need fever plus one other symptom, malaise, myalgia, headache, conjunctival injection, pharyngitis, abdominal pain, vomiting, diarrhea with or without blood, any type of unexplained hemorrhage, or a erythematous macular papular rash on the trunk. So fever plus one of those should make you start thinking about travel. And that's good medicine anyway. That's just good health care. Somebody comes in with a fever, you want to know where they've been. Could this be infectious? Could it be something foreign? Do you need to call public health? So the worry about travel is that if somebody has traveled to a specific area where we know there's Ebola in the last 21 days and they have these clinical symptoms that could be Ebola, that's what's going to trigger you into calling the medical officer of health, which is why I was smiling, because that's me, for CDHA during business hours. So when there are more countries that the Ebola spreads to in Western or Central Africa, they will make it onto our screening tool. This will be kept up to date. And at this point in time, you can see that we've got Sierra Leone, Liberia, and Guinea, the most affected countries, Democratic Republic of Congo with that other Ebola outbreak that's happening in Nigeria. We have one case in Senegal now as well. So this is the screening tool that will be used. Once somebody screens in, the next call goes to the medical officer of health. And during business hours, that's the medical officer of health locally, so for CDHA. The phone call is 902-481-5800. And that will be triaged right to me. If I'm not there, Dr. Watson Creed, the other medical officer of health, will take it. On-call, public health has coverage 24/7, and on-call through QE2 locating will be able to get you a medical officer of health on call within 30 seconds. And at that point in time, the MOH will then trigger a teleconference discussion with ID through EHS to figure out what we need to do. And this isn't just going to happen at the emergency department at the HI. 811 know of this algorithm, EHS, all the emergency departments, 911. So all of Nova Scotia is using that same entry into the system. And the medical officer of health will lead the triaging down to a more minute detail that it's not fair to ask our frontline staff to have. So we know where in Nigeria the cases are, and if somebody just flew through the airport, they would have a much different risk exposure than if somebody was in one of the areas where there are more Ebola cases. And so that's why the discussion is going to happen with the MOH. ID will be brought in to discussion to look at the clinical symptoms, to decide if we need testing, where it's going to be done, how we're going to transport the patient. So I think my final message would be we have a really good plan. We continue to develop the plan, which I think is why it's a good plan, as new information comes to light. And it's going to be a great plan when we get our malaria cases that present like they could be Ebola, and because Ebola itself is extremely unlikely.
There's lots of messaging that is going on with the province that basically is, that's okay, that is mimicking what's going on with the rest of Canada, and it essentially is fancy pictures that just outline exactly what Dr. Taylor just went over. So, what does the future hold? I always love these predictions because whenever I make them, I am inevitably wrong. The risk in Nova Scotia really is low. This is a graph or a picture that was from a recent report in PLOS Currents Outbreaks, and it really just shows you the travel from an airport perspective from the areas of concern. You can see that Nigeria is kind of a hub in Africa for a lot of airport travel, so that would be a huge concern if it became more widespread in Nigeria, but as Dr. Taylor said, it really is one cluster at this point. You can see that the little circles give you an idea of volume. So, you know, a big circle like this is 6,000 passengers a week or more. A small circle like up in Canada, you've got 300 to 1,500 passengers a week. So there is passenger travel from these areas, but it is not high in Canada. There is no direct flights to Nova Scotia. Doesn't mean that something couldn't be diverted, and there are plans for that as well. But this is really to reflect that really, for Nova Scotia's perspective, the overall risk is low. So where are we headed? This is very interesting. And this is the potential scary part of the talk. Because we are now in a logarithmic phase of the epidemic, meaning that the cases are increasing very, very quickly. So this is the latest epidemiologic curve, and that's basically all the cases that have been documented in each of the areas which are color-coded, and you can see that we are now kind of in a logarithmic increase. Now, if you plot that on a log scale to try to make it linear, you get kind of a model. This was actually published in Science in August 31st, so the model was probably developed sometime earlier in August, and they predicted that if you use our data from September 12th, that we would have about 5,000 cases. So they're pretty spot on with their model, which I thought was interesting, because models depend on what you put in is what you get out. Now the scary part is if this goes uncorrected, and the model follows a similar linear fashion on a logarithmic scale, by March of next year we'll have over 100,000 cases. So if it's restricted to those countries, then again, the risk to our area is low. But this Ebola outbreak really reflects the problem of living in a global society when not everything is equal. Places in Africa are extremely poor. They don't have the resources to manage these infections. Inevitably, that will spill over into a developed country, and at some point, the world will wake up and realize that it's a problem. So that's just what the predictions are, and who knows what really is going to happen. It depends on whether this virus, a lot of people, we don't know everything about this virus. The virus, as I said, usually comes in, targets people, kills them, and then disappears for whatever reason. Will it burn out in this outbreak? Some people theoretically think it will. Could it mutate and become different? That's possible as well. So there are lots of unknowns. But what is true is that the world as a whole needs to respond to this. It's not an African problem. So what are the potential treatments out there? A lot of you have probably heard about ZMapp. So this was the experimental drug that the American missionaries were given. It is made more widely available. It's kind of cool, actually, because what it is, it's a monoclonal antibody. It's an antibody that is targeted against the virus. And remember I said that people who survive, it generally corresponds to the time that their body makes antibodies. So if we can give them antibodies, then theoretically you should be able to help their body overcome the infection. And what it's done, it's grown in a tobacco-like plant. So these are actually plaques. So the plant is infected with a virus, not the Ebola virus, but a plant virus that expresses these Ebola monoclonal antibodies. So you can actually make antibodies in plants. You can, make it a big farm creating this drug. And there is some thought that it may be beneficial. The caveat to all this is that as we rush bringing drugs to market, if we don't do it in the appropriate scientific manner, we'll never know if it actually works. Because too often we've thought things have worked, and then when we looked at them using the scientific method, we found out that the value is just not there. Now with Ebola and the mortality rates, people have moved this forward more quickly, and the WHO has held ethical consultations on what to do with these experimental vaccines and drugs, and they are moving forward with them. And Canada is actually at the forefront. These two vaccines that have been available, a lot of work was done at the National Microbiology Lab in Winnipeg, one of the few level 4 labs, and Ebola being a level 4 pathogen, around that could actually handle this. They did monkey experiments. They helped develop the vaccine there, and that's being rushed to market as well. And there are a couple of experimental antiviral drugs that are out there as well, which will be interesting to see how that plays out. So there is potential for therapies and prevention in the future. So this is my conclusion slide. You can look at it as a glass half empty, glass half full situation. The benefit of this exercise, and people will often ask, well, why the hell are you spending all this time on something that has a very low risk of actually happening? Well, it reminds us of a couple of fundamental changes in healthcare that we need to remember. One is that you have to review every patient you see to see what is the risk to me. So this sort of bedside risk assessment model is the new paradigm in infection prevention and control. You need to look at the patient, what are their symptoms, what am I potentially exposed to, and you choose the appropriate protective gear based on that. So that's the new thing. The other, well, it's not new, but it's trying to be more and more reinforced. The other thing that needs further reinforcement is that we should be asking everyone where they've been. In infectious diseases, we always ask where their travel is and a whole bunch of other social-related questions. This is important because I suspect that you're probably going to see more MERS-CoV or H7 or one of these other respiratory pathogens in the next couple of years. And in order to be able to really think about that, we need to know where people have been. It's where they've been and what they've been doing that's really going to influence whether we can test for them. And again, it influences how you protect yourself. So this all hazards approach is the new way that that we should be thinking about new infections. So that's sort of, by the fact that we reinforce those concepts, I think this exercise has been worthwhile. Remember, the risk is low in Nova Scotia currently, and you have all of the tools available to you that can protect you from infections like this. So with that, I will end and be happy to answer any questions that you may have. Jack.
Due to the poverty, has the World Health Organization looked at perhaps supplying proper PPE or,
So there's certainly been talks, and the World Bank has, suggested that they will give a certain amount of money. Bill Gates is putting money towards some of these therapies and stuff, but the fundamental personal protective equipment, that's where the lacking is. There is calls that come forward. There's also calls for volunteers from a medical perspective, because as the logarithmic phase hits and more people get infected, you're going to need more and more healthcare workers to help try and treat and prevent further infection. So their call for volunteers and money has gone out.
With regards to Dr. Kedford, the American Hospital Association, they to Atlanta, he was diagnosed, but then they cured him of this Ebola. So when you say cure, does that mean all the symptoms possibility?
There's no chronic infection with Ebola. The virus can still be within his seminal fluid for up to 3 months based on some of the information that we have. So once he's recovered and going to survive, he can actually still spread it through sex. There is no chronic phase to it. I don't think there's enough knowledge to know if he became immunosuppressed whether that focus would actually cause more damage. But all of the data to date would suggest that once you've generated an immune response, you've then crossed that hurdle to overcome the infection. So there's never been evidence of a recurrence of the infection once that people have recovered. Steve.
Maybe a theoretical question. And I think I know the answer, but the decision by whoever it is has been that if there's a suspect case in Nova Scotia, they're all transferred or other CDHA.
Correct.
My question is, I guess, why? If you talk about this in terms of the management issues, to be honest, from what we're being told, the management is good infection control measures, which theoretically every hospital in the province is already doing or is capable of doing, and the medical therapy is aggressive supportive care, which again, the level 2 centers at least should be able to do. So the risk-benefit of transferring patients who are at risk from one region to another region, somebody must have done the calculation. It's not like we have a resource here other than certain specialists who are contactable by phone. But there's no specific cluster of equipment or something that's only here, period, full stop. So why are we transferring potentially infected patients?
So the main reason for that is the lab processes are completely different. So to transport the blood, people have to be TDG trained. The decision's been made not to use large analyzers, which are all across the province. Many of the other labs don't have great capacity when it comes to microbiology. Most of the testing is in a core lab environment. And the point-of-care equipment is sort of the way that most people are approaching this, not only here but across the country. Now, whether that changes in the next few months, that may evolve as more manufacturers come up with recommendations about decontaminating automated analyzers. So because of that, it's possible that we could do that to all the regional labs, but that means the regional labs would have to maintain the capacity for point-of-care equipment, which is about $30,000 for each lab. They would have to make sure that there is an on-call technologist who's able to package them appropriately, test them appropriately every day. So we felt that the most cost-effective strategy to ensure that Nova Scotia can respond to a possible case, and again, the cases are unlikely and the chance that this is going to happen is low. The most cost-effective way is to centralize it. We've got one core group of technologists who are on call 24/7 so that they can respond to that. And if need be, if someone, there is the caveat that if someone is too sick to be transported, so if someone truly has vomiting, diarrhea, bleeding everywhere, and they're really going to put more people at risk by moving them to CDHA, we can then actually bring the lab to them. So the point-of-care equipment can actually be moved to them. As Nova Scotia changes and the lab system changes and more point-of-care equipment becomes available, which is one of the initiatives that people want to move forward with, that may change. But right now, it's the most cost-effective way to prepare for something that is low likelihood.
Todd, I'd like to ask a question or put something on the table just for you to kind of explain to us, because I know it's a common question that I'm hearing a lot.
Sure.
So we're talking, a lot of the presentation focused on that droplet precautions are generally considered adequate except in certain procedures. So my question relates to the decision, if you could kind of explain to us the decision made to require negative pressure rooms and put these potentially infectious patients in an environment with sort of the most immunocompromised patients that we have, being 3 in ICU. So just like you just kind of explained
absolutely.
that, just because I know that's a common thing on a lot of people's minds, are the other patient population.
It's a great question. Dr. Taylor alluded to it in that when these patients present, they have the potential, if they truly have Ebola, to deteriorate quickly and require aerosol-generating procedures. So you actually reduce the risk to the healthcare system by making sure that they're in the appropriate room to start with, rather than moving them around. They have an ante-room, which means that you can take your PPE off and on much more controlled. And again, it's the PPE that's going to prevent this infection. It's not aerosol transmitted, so you don't have to worry about other people in the unit to have it, but it's the fact that you can dedicate someone in a room that could be used for aerosol generating procedures, that you don't have to move these people around. So that was really the reason why, and that's not only here, but across the country, that's where they're moving to. It isn't an aerosol generating, you don't have to worry about aerosol generations unless you do something that causes an aerosol to be generated. But if you had it in a different place, then you'd have to move them, and moving them around at the point where they're that sick. Because you got to remember, again, most of the time it's only going to be 48 hours or so before we can say, okay, they don't have Ebola anyway, and it's back to standard of care and they can go wherever they want. But if we actually do prove that they have Ebola and they do poorly because they get DIC and start to bleed and that sort of thing, then it's better to have them in the most contained environment possible. Is that a reasonable question?
What's the process that they present at the family physician's office?
So if they present to a family physician, again, the messaging is that if they have fever plus one of these other symptoms, and again, this has gone to all physicians in the province, that the patient be isolated so they can stay in their patient room. They get put on a mask, and that physician calls the medical officer of health immediately to discuss what that risk is. And then from there, if they think that it is an Ebola potential patient, EHS will then pick them up from that doctor's office and transport them to QE2, essentially. Yep.
What special cleaning needs to be done for equipment?
So
when they're no longer there?
So again, there's confirmed and probable cases. A probable case, you've got 48 hours, so you can quarantine equipment and not have to worry about it anyway. Most times we generally will use disposable things. The things that can't be disposed can be decontaminated with our regular decontamination procedures, because the virus is not a particularly hardy virus. It is actually easily inactivated with typical cleaning agents like low-dose bleach, for example. The Virox wipes and stuff like that will all take care of.
So, for instance, the bronch, if it were used, it's just a normal thing?
Normal cleaning procedures. We would, as a precaution, because you always take things out of circulation until, again, you can rule it in or out, but the cleaning procedures that we have currently available would be acceptable for that sort of stuff. You got to remember, we do this for HIV all the time, right? So HIV is another envelope virus. We scope people with HIV. We bronch them because they could have PCP. They can have viral loads in the millions. And the processes we have in place are adequate to clean those particular pieces of equipment. We know what happens when they're not cleaned properly, because there have been cases of bloodborne pathogens due to poorly cleaned equipment. But ensuring that we use the standard procedures, it should be fine. Any other questions? All right. Thank you for your time.